Thanks for staying with us. This is still New Day on Signature Television. Now, men, gather round. And of course, it's information for the women that love them too. We're talking prostate. Everything about prostate and the issues around prostate, including prostate cancer. And we are here in the studio with someone who is going to do justice, good justice, to this topic, in the person of Dr. Obinna Anikwe. Dr. Anikwe is a consultant urologist at Raymond Anikwe Memorial Hospital here in Enugu. Dr. Anikwe, thank you so much for joining us this morning.
Thank you very much, Iggy.
I must say, you're looking good.
You too.
Thank you so much.
Thank you very much.
Thank you. So, Doctor, quickly, I'm sure someone out there wants to know exactly what is prostate. We're talking to lay people who want to understand. They hear this every now and then, prostate. So what exactly is prostate?
All right. Thank you, Chidi. Well, let me start first of all from the word prostrate. It's actually not prostrate. It's the R is silent, the second R. Okay. So it's prostate. But it's a general problem. Many people do that. So urologists, we are used to it, but try it as much as possible. So it's an organ that is only found in males. It's an accessory reproductive organ. That is, it's an organ in the male that helps in the reproductive activity of the male. Okay. It's usually found under the urinary bladder of the male and helps in contributing to the semen that is involved in reproduction. Okay. Yes. So that is what the prostate is. And for those, is a very small but important organ that facilitates reproduction in men. So the diseases or disorders associated with it are of primary importance to men. Thank you.
So what are the main common prostate problems affecting men today in our society?
Well, there are many, but I'll just basically highlight on three. Okay. Starting from what we call prostatitis. Prostatitis simply when there is an inflammation or an infection involving the prostate. It's called prostatitis. Then the commoner ones people are more used to when there is a tumor or let's say a growth in the organ. The growth can be a normal benign growth that occurs with age, or what most people refer to as cancer or malignant growth. So for the one that is non-cancerous or benign, we refer to it as BPH. BPH means benign. Benign means it's not malignant. Yeah. Prostate hyperplasia. Hyperplasia is sort of a growth, increase in the number of cells in the organ. Then the other one that I said is cancerous or malignant, we refer to it as cancer of the prostate or CAP. Right. So the three disorders I mentioned now are prostatitis, which just involves infection of the prostate or inflammation. Right. BPH, benign prostatic hyperplasia, which is an increased growth that is not cancerous, and the cancerous type, which is cancer of the prostate or CAP. All right. So prostatitis, BPH, CAP. CAP. Yeah. All right,
Dr. Anikwe, at what age, you've made it abundantly clear that this concerns men, because the organ is only found in men. Now, at what age does this organ become active in a male individual, and what are the predisposing factors that could point to any of these, malignancies and diseases?
Okay, yeah, usually from, let's say, from the age of 40. Okay. Most of these disorders from the age of 40.
Is there a particular reason to that?
No particular reason. It's just, most of them are disorders of aging. Disorders of aging, unless the person doesn't want to age. But most of them are disorders of aging. So we take particular note of these disorders usually from the age of 40. Okay. That is when we advocate for screening, especially for the one that is bad, that's the cancerous one. Yeah. So it's usually from the age of 40 that we do the screening. I'll do more on the benign growth, the increased growth, the tumor, benign and cancerous. That is BPH. Thank you. That's a nice diagram. The BPH and the CAP. So it's usually from the age of 40 that we advocate screening for us to help detect these two conditions, especially the cancer, which, as we know, cancer has really no cure, but early detection is key for us to be able to do something meaningful to arrest the growth. Because,
So what's the difference between the BPH and the prostate cancer? Yes.
Well, the difference is in the BPH, most men, as you age, the prostate gland increases in size. Actually, the size of the prostate gland is about 18 to 25 grams. And for those, we refer to it as being walnut shaped. In Igbo, opa.
Walnut.
But walnut is a sort of a fruit. So that's the shape, and the size is about 18 to 25. As you grow in age, males from 40,
18 to 25 grams.
Gram is the normal size of the prostate. But it can grow to as much as beyond 100, 200. In fact, we've seen some cases 500. So as one ages, the prostate grows in size. And it's not a must that it will give you problem. No, it's not a must. It can even be big and you might not have symptoms. It could be, let's say 40, 50, and the person develops symptoms at the age of 50. It could get to 80 when you're about 70 something and you won't have any symptom. So, but it grows in size from 40. Now, the problem is that sometimes the growth becomes autonomous, that it becomes malignant, that's cancerous. The difference between the normal growth that comes with age and that cancerous is that when it becomes cancer, it can spread to other vital organs like the liver, lungs, brain, bones, and now cause more problem. But the one about the normal growth might just give you compressive or obstructive symptoms that won't spread to anywhere. So that's the difference between the BPH, that's the benign one, and the cancer of the prostate, which is the malignant one.
Okay, before
please.
You chip in, I would like to know, what are the symptoms?
Beautiful. Now, the symptoms are almost similar for the benign and the cancerous. We have two classes of symptoms. We have what we call the obstructive or voiding symptoms. The person might have a weak stream. If you, Alice Joshua, right?
Yes.
Good. When we were kids, I don't know whether you did it, but for some of us then that were living when Nigeria was still okay, interacting with neighbors, young boys will come together when they want to pee. They will be doing competition whose pee will project further. Great. So when you are younger,
you guys are leaving me out of all the fun.
The pee can go a long distance.
Yes.
But as you grow in age from 40, when they start setting in, the person has a weak stream such that it won't even progress further, not much from the distance where you are standing. So one of the symptoms is what we call weak stream. Now we have another one we call intermittency. Normally, when you don't have any of these problems, when you start the process of micturition or peeing, it just goes in one flow, one stream. But intermittency, when it goes cuts before you finish. It doesn't go in one stream. Intermittent flow, intermittency. Then you have what we call straining. When you want to urinate, ideally, when you don't have any of this problem, you just get to where you want to and start immediately. But in this condition, when you have benign prostatic hyperplasia, you strain first. You sort of strain before that process of weeing commences. Then the last symptom for obstructive is what we call feeling of incomplete emptying. After peeing, you won't have that satisfaction that you've emptied your bladder. You still have that feeling that something is still remaining. Let's say in the next 5-10 minutes, you go again to pee. That's for the obstructive stroke voiding symptoms. Then we have what we call irritative stroke, how will I call it now? Irritative symptoms or storage symptoms. Frequency is one of it. When you go to pee, maybe less than 1 to 2 hours, you go again to pee. Urgency. Like now we're in a studio. If I don't have any problem and I have an urge to micturate or urinate, I can hold it till after this program.
Sure.
But if you have this problem, you cannot hold the urine. You have that urgency to go and pee immediately once that feeling comes. If not, you can start peeing around there. Then the last one is nocturia. Nocturia is when you pee so much in the night. Ideally, when one goes to bed, you don't wake up more than 2 times to go and pee before daybreak. But when you have this problem, some cases 3, 4, 5 times every 1 hour, every 2 hours till daybreak.
Yeah.
So these are things that give us an idea that a patient, you don't need to have all these symptoms. 1 or 2 can be indicative that this problem exists in the patient.
Yeah, still.
Now, for cancer, cancer still has all these symptoms I've listed, with a few more, like bone pain, waist pain, because cancer spreads. And the commonest place it spreads to is the bone, the lumbar, the spine, the lumbosacral, and the hip. That's the commonest place. So the person can come with bone pain or waist pain. The person can come with paraplegia, that's inability to walk or weakness in walking, paraparesis or paraplegia. Can come up with hemoptysis, that's blood in sputum, because of the spread to the lungs. So anywhere it spreads to, it can manifest as a symptom. Like if it spreads to the liver, the person can come with jaundice, that's yellowness of the eye. Some cases they spread to the brain. The cancer can spread
Travels
to the brain.
that far?
Oh yeah, oh yeah. Headache, persistent headache, incoherent speech. Those are pointers that this might exist in the patient.
All right, doctor, this is really enlightening.
Thank you.
And there are some of the things you mentioned. And I, for one, I know that late presentation is the bane of treatment, in our healthcare, ecosystem.
Yeah.
Now, some of these symptoms that you just listed out are actually symptoms that go to show that the sickness has progressed.
Yeah.
So, at what point could a man say, okay, this could be this, let me just go and get myself checked? Because most of the time when they present, it's usually late. So what are the telltale symptoms that someone can actually see and say, hey, I think there's an issue, let me go see the doctor now and see how we can mitigate this issue?
Yeah, thank you very much, Chigi. Before I talk about the telltale symptoms, it's good for our viewers to know that they shouldn't wait for this. I'll mention the telltale symptoms, but it's good for our viewers to understand that they don't need to wait for these telltale symptoms. Ideally, in our environment, every man up to 40 years of age, in fact, it's advocated that blacks 40 years should go for screening. Screening involves a simple test. It's just a small blood test, and you do what we call PSA test.
Are blacks more predisposed?
Oh yeah, blacks are more, in fact, CAPD cancer is commoner in blacks and more aggressive in blacks. Several studies have been done, especially in US. US is a sort of a cosmopolitan society where you have Asian Americans, white Americans, black Americans. It's been seen and noted that in black Americans, it's commoner, and not just commoner, it's more aggressive. So blacks, it's been advocated that blacks from 40 years should go for screening. Whites from 50 years should go for screening. Don't wait for the telltale. I'll still let the viewers know the telltale symptoms or signs. But it's from 40 and 50, go for that simple test. Prostate-specific antigen. Just a small blood test. The normal level for that test is 0 to 4 nanogram per ml. Anything above that 4 nanogram per ml might be suggestive. Then there's another clinical examinations doctors do. We call it digital rectal examination. Digital, the digit. You insinuate your finger through the anus of the patient. Through there, you can examine the prostate. There are some features with your finger an expert can use to detect if there are things suggestive of cancer being present. Before you can now go for a further test that we call prostate biopsy. Now, for the telltale symptoms we are referring to, once, apart from the obstructive and irritative symptoms, which we call lower urinary tract symptoms that are earlier listed, if you start having bone pain, especially from the age of 40, 50, a man, don't just think, oh, it's arthritis, oh, it's this. Present to a doctor. Let the doctor be sure it's arthritis. By then, he can do this screening test I mentioned, PSA and digital rectal examination. Or some might just come and present with weakness in walking or inability, all of a sudden inability to walk. And they might not have any urinary symptom. It might just be the first presentation. So that high index of suspicion, when you know this is a male, the age bracket from 40, 50 and above, you think about it and do the screening test. If you find anything, promptly refer to urologist to take over management.
Is it quite possible?
Yeah.
Because we've emphasized on the fact that it's from 40 to 50 thereabouts.
Yeah.
But is it quite possible that somebody who is of lesser age
can
have this?
Oh, yeah. In fact, we've had some cases of 30-something-year-olds having cancer of the prostate.
What could be the reason?
There's no particular reason. In fact, the bad thing about it is that the younger you get it, the more aggressive the cancer is. Ideally, cancer of the prostate is a slow-growing disease. It's a slow-growing disorder or tumor. But when you get it in these younger age groups, for cancer of the prostate, you find it commonly from the sixth decade, that's 50 to 60 to 70 above. But when you get it in the younger age group, like 40, 30, it's usually more aggressive. And the prognosis means outcome of the disease is worse than when you get it in the older age group. In fact, when you get cancer of the prostate in the older age group, because it's a slow-growing tumor, the person can live with that cancer and die not due to that cancer of the prostate. You know, at that age group, there are so many comorbidities like hypertension, diabetes, all struggling to be the first one to knock the guy out. So he can live with that cancer at that higher age group. Unlike in the younger age group, when it occurs, it's more aggressive and the outcome is poorer.
Thank you very much. I'm sure a lot of people are waiting to hear about prevention or how can I prevent this. But before we go there, I would like to ask, is it quite hereditary? Is it possible that the father can pass it to the son in such cases?
That's a good question. Thank you, Joshua. It's not really hereditary, but it is what we call familial. Familial in the sense that the risk factor, that's the risk of developing this condition, cancer of the prostate, is higher for one that has a first degree relative. Example, let's say someone's dad had cancer of the prostate and another family, no history of cancer of the prostate is in that family. Guys or males born in the two families have different risk, their susceptibility to developing it. Those males coming up from the family with an already established history of, like say, the father, the uncle, or the brother, first degree relative. The male in that family has a higher risk of developing cancer of the prostate in future, unlike the family where there has not been any established person that had that condition. But all these things are not foolproof. That maybe, let's say my dad had cancer of the prostate, doesn't mean I must get cancer of the prostate. In another family, because a guy there of the same age group with me, because the dad didn't have it, doesn't mean he can get it. But the chances, we are talking about probability and chances, is higher where there's an established family history of cancer of the prostate. That's why we say it is familial, not that it's hereditary.
What is the clear-cut difference?
Well, the clear-cut difference has to do with genes. Just like you say, high BP runs in this family, or let's say diabetes runs in this family. The same way, you can say cancer of the prostate is familial. It's just to know the chances of developing it in future. Like a family with that history, that someone has already developed it, males in that family are advised to be extra cautious. That's to go for screening. In fact, the idea of screening is more important in males coming out from that family than where there has not been an established family history. But remember that family history starts with one person. So where it wasn't before, it's not a must that nobody ever will get that family. There must always be a first person. That advocacy for screening is very important for every male, whether you have that family history or not, because you can never know who the first person there will be.
Okay, doctor, is there a physiologic relationship between sex and the reduced probability to contract or to develop prostate cancer?
Thank you very much, Iggy. I don't think there's any program or any advocacy meeting I've been involved in that I've not had this question. Now, there are various schools of thought. There are two schools of thought. One school of thought believes that when that's when you indulge in sexual activity, that increased or frequent sexual activity helps to reduce the chances of one contracting or developing CAP or cancer of the prostate in future. Another school of thought believes there's no much difference whether you are firing or you are not firing. But for me, if you are married and you are not losing anything by doing the normal thing you are meant to do, which is firing, if it can help you, you don't lose anything by firing. So for those in the other school of thought that believe it helps, do whatever you can do in an organized fashion, as in a marriage or something like that. Do as much as possible, fire as much as possible. If it will help you, good. If not, but still do the basic things you need to do, going for screening and taking particular note of it.
I have one issue too. I would like you to trash out.
Yeah.
Now we are talking in the realm of hypothesis, right?
Oh yeah.
And you're a scientist, and there are many more like you.
Yeah.
Is there any ongoing research to find out if there's little truth in this hypothesis?
Well, as I told you, that's why you're saying school of thought. School of thought means people have done some researches. Some have done some researches and said, oh, there's not much significant difference. That's the school of thought that doesn't believe it helps much. The other school of thought believe, oh, maybe there's just a slight, but it's still something to hold on to.
But what is the cohort really?
Really about it?
Yes.
Well, for now, I can't really say. I think there still might be some ongoing studies to lay this controversy to rest. Yeah. But as I said, it's important for us. In fact, that is the difference between us and the Caucasians, the whites. In fact, two things they don't joke with: vacation and this going for regular medical checks. Us here, down here, we don't do that. We wait till either we are knocked down or we have some symptom. Even if we have symptoms, we go to the nearest chemist. Till that can't even help us. That's when we remember the hospital. In Nigeria, or let's say Nigeria, we have, at least most people that have cars, there's nobody that has a car that won't say he doesn't service his car at least once or twice in a year to go and change oil, because he knows if he doesn't do that, the engine will do what? Knock. But we forget that the greatest machine in this world is the human body which God created. We don't know that this human body is like a machine and it needs servicing. And what is the servicing? Regular medical checks. Ordinary going to check your BP. Ordinary going to check your blood sugar. For adult males of this age group we are talking about, going to do your PSA and digital rectal examination. All this helps to make us present early if there is anything there. And when we present early, the chances of cure is possible. But late presentation, what is left for us is what we call palliative care. You have headache, treat, have pain. You're just trying to improve the quality of life as much as possible till the person goes. So it's key.
So are there particular lifestyle that can, significantly impact this?
Well, that's preventive strategy. That's another important question. Thank you very much. Now, the etiology means cause of this, especially cancer of the prostate, is relatively unknown. But there are some things we know, like cancer of the prostate, that the pathogenesis or what brings it on is androgen dependent. Androgen means...
Androgen is a hormone?
Great. Testosterone, male hormone.
Okay.
Just like in females that have breast cancer, talk of estrogen, the female hormone. The equivalent in male is cancer of the prostate, male hormone. So it's a male hormone, is a androgen dependent tumor. So all we are doing is trying to reduce the androgen, the testosterone level, to sort of starve the tumor. You understand? Now, risk factors. We have what we call positive risk factors, that is things that likely to predispose to cancer of the prostate, and negative risk factors, things that reduce the chances. And most of them are dietary. Apart from age, I mentioned nobody can prevent age. At the more is a disease of advancing age. Race, we've talked about blacks. It being commoner in blacks and more aggressive in blacks. You understand? Now, dietary / environmental factors, things we consume, positive risk factors that can increase the chances of cancer, increased consumption of animal stroke fatty acids, saturated fatty acids, like found in red meat. You know, we say white meat is healthier. White meat like chicken, fish, turkey, healthier than beef, red meat. Apart from even cancer of the prostate or prostate problem, gout, for those that have gouty arthritis, red meat has equally been implicated, excessive consumption. So for these positive risk factors, you try to reduce the consumption. I don't say don't eat at all, but just balance. Thank you. Now for the negative risk factors, things that reduce the chances of one developing cancer of the prostate, increased consumption. Something like lycopenes. Lycopenes are found in red tomatoes, red tomatoes, soy products, green tea, fatty vitamins A, D, E, some trace elements through minerals like zinc, selenium. Remember zinc when during COVID era?
Yes.
Everybody, the zinc. It was good for the prostate too. So zinc, selenium, that trace elements. So such negative risk dietary factors, we advocate for increased consumption. All these still are not foolproof. That you consume these ones that are indicated for it doesn't mean you can't develop cancer of the prostate. Do you understand?
Yes.
So those are the things studies we've seen to help us, but you still cannot overemphasize the importance of this early
constant
script.
check.
Thank you, my sister.
Let's talk
annually.
early diagnosis, because just like you have with your cars, you know, there's this thought that diagnosis is usually not, 100% until the patient presents with all this, very bad symptoms. Just the way it happens with cars. If you take your car, you notice a little bit of noise, you take it to the mechanic will tell you, madam, Oga, we can't detect anything. Now, my question to you is, how good is our early detection of prostate? And can, you mentioned imaging or something. Can, tests like CT scans detect, be spot on in detecting these things early enough so that it can be treated?
Thank you, Chigi. Yeah, it can. Those are modalities available for us, investigative modalities. Like I said, you start off with a PSA, which is a biochemical test.
Okay.
You go to the clinical test, digital rectal examination. Then you have the radiological test. You start with a simple ultrasound, either abdominal ultrasound, but we recommend more the one you put through the rectum.
Endoscopy?
No.
Okay.
Transrectal, through the rectum, ultrasound. Okay. It will give you some features. Usually, hypoechoic features or lesions are suggestive of cancer of the prostate. But you don't just stop there, because it's still subjective. These three modalities are still The objective way is what we call prostate biopsy. Biopsy means taking a sample of an organ and now sending it to another group of doctors, specialists called pathologists, the histopathologists. They will look under a microscope the tissue you send to them, and from the microscope they can see normal cells or abnormal cells. In fact, cancer cells are like all these autonomous local governments we are finding everywhere now. Autonomous is that it doesn't now obey the normal body regulation than just growing arbitrarily. Okay. So they can detect those types of cells and now tell us this patient has cancer. Now, you can go further to even know whether that cancer has gone beyond the prostate by using those modalities you mentioned, like CT scan, magnetic resonance imaging, MRI, even scintigraphy, bone scan, that will detect hot spots on the bones. Those will now tell these other additional modalities will help us detect if there has been any spread beyond the confines of the prostate.
How affordable is diagnosis of?
Presently, diagnosis, not like before, things are coming down, at least basically, apart from this present economic, with all these things are dollar denominated. We don't produce any of those things. But before, they were relatively affordable, especially in the teaching hospitals, where there's a sort of subsidized cost.
Can you give us numbers?
Oh, okay, well, I think CT scan should be around 50 to 60,000. MRI maybe around 80 to 90,000. But bone scan and all those ones might cost a bit more. But we're talking about life here. People spend much more on other things.
Okay, so concerning the treatments and all of that, what are the major side effects that can come out from having to start treatment? Yes.
Well, remember I told you that the cancer of the prostate, the way it evolves is an androgen-dependent process.
Yes.
So what we are trying to do when we are trying to manage or control that cancer of the prostate is to limit the level of the testosterone, which actually feeds the cancer. Now, when you do that, either by giving injections for cancer of the prostate, there are some injections like Zoladex, we call it Zoladex, Goserelin, which is a form of medical castration. You know what castration is? Good. Now, we can equally do surgical castration because 90 to 95% of the male hormone, testosterone, comes out from where? The testes. So by removing the two testes, we call it orchiectomy.
Different from vasectomy?
Yes, vasectomy is the vast difference. That one, you just remove the vas deferens, especially for those that are satisfied, they don't want to procreate anymore. There is much difference from that, yes. Orchiectomy is for cancer of the prostate. You are trying to starve the cancer from that food source or the testosterone. 90 to 95% comes from the testes. Now, about 5% still comes from an organ, a small organ on top of the kidney. We call it the adrenal gland or suprarenal gland. So you now give some drugs, what we call anti-androgens, something like bicalutamide, Casodex, to now mop up the few testosterone, 5% coming from there. The aim is to starve the cancer. Now, for a male, the male hormone is important for a male, normal health of a male. So there are some side effects that will ensue when we reduce that male hormone. Something like the man might start having enlarged breasts, what we call gynecomastia, can start becoming weak and all those things. But it's a sort of balance. You're trying to weigh the benefits through side effects. If the benefit outweighs the side effects, we go for it because cancer, we're trying to save life. So the patient, you have to enlighten the patient on the possible side effects that might ensue. So that once he knows about it, he just has to manage and will try to manage those side effects.
So what role does exercise play in this?
Exercise, for general health, exercise is important for general health. Like obesity, some recognize obesity as a form of risk factor for developing cancer of the prostate or virtually all the cancers. So exercise, anyone that exercises regularly most likely won't be prone to being obese.
But that doesn't rule them out.
No, that doesn't rule it out. But exercise is advocated for the general well-being of an individual. So it's always advocated for any condition.
Let's talk surgery.
Okay.
I would say there's also this school of thought that says once an individual goes under the knife, the outcome is usually grave. So what usually is the prognosis after surgery for prostate cancer?
Thank you. For prostate cancer, actually for prostate, we hardly do surgery for prostate cancer. Just the one commonly with that notion about prognosis, usually for BPH. Because in the past, people believe that when you operate on the prostate, that they bleed so much or they don't recover, or if it's cancer, it proliferates. Now, when you operate for prostate cancer, you only operate on prostate cancer when the cancer is still localized within the prostate. Then we do what we call radical prostatectomy. Ectomy means removal, so prostatectomy simply means removal of the prostate. Entirely for cancer of the prostate. But under one condition, that it still has been confirmed to be localized. Because if it had spread and you go to do that, you're just aiding the spread. Okay? Now, we call it radical prostatectomy. That could be open or even through laparoscopic without opening.
Oh, wow.
Yeah. Now, for the benign condition, BPH, that's where that notion of people not surviving proper, that was far back when there was a lot of bleeding. Presently, both open or using endoscopes, endoscopic prostatectomy, what we call TURP, transurethral resection of the prostate, or even laser, using HOLEP, whole immune laser enucleation of the prostate.
Are these obtainable in Nigeria?
Oh, yes, they're obtainable in Nigeria. What I don't want to discuss is the cost, but availability, in Nigeria. and the outcome is beautiful.
Very quickly,
Yeah.
very quickly. We all know of medical practitioners, people who would go on air and tell you, you don't have to go under the knife. We have a way of melting these things out from your body. You don't need to go to the hospital and spend so much and go under the knife. What do you have to say about those?
Thank you very much. This is very, very important because that's why we are really investing much in advocacy, because those medical are really our rivals. And you'll be shocked that even some learned people in quotes, educated people in quotes, still patronize them in this era. You know, in the past, people used to think all these prostate conditions are sexually transmitted and they hide the disease and they don't really present in the hospital. There's no prostate condition, whether prostatitis, BPH or CAP, has nothing to do with sexually transmitted infection or disease. So we encourage people now to come to the hospital and get adequate treatment. All those myths and going to medical, the problem is that they spend all their resources there, and when it becomes so obvious, especially the cancer, such things help in us seeing late presenters, because they waste those valuable moments where much would have been done to control and contain that cancer. When it becomes obvious, even to the patient that presented himself to the medical quacks in quotes, they now come to us as late presenters, and by then, we can do magic. It's now palliative care, because they are late presenters. But any male that, let's say, has any urinary symptom, I mentioned, weak stream, frequency, nocturia, you don't need to have all of them, one or two. Present yourself to a hospital. From there, we can even detect that there might have been a cancer that hasn't even started manifesting. So catching it early is key. And you can control it well with some of these gamut of modalities that earlier mentioned. So I plead and ask our people to, we're in a very, how will I put it, new era or jet age that we can still be talking about tradomedical. There are some things you can use herbs, don't get me wrong. Do you understand?
Yes.
But hospitals are now, even in the villages, present to at least seek a second opinion. Seek a second opinion while it's early, while there is daytime. Because if you present late, even the doctors can't do magic. Doctors can't do magic. We're not God, just that God uses us.
Absolutely.
That is it.
Okay, so finally from my own end, I would like to know if there have been much more, exposure to this. Do people have much more, do people know about this? In your own experience, have you met people who don't even know that they have these things and, cause more problem for them? How has exposure been?
Yeah. I've met at least people that don't even know. Some are afraid of having open surgeries. They believe, once they use a knife on them, they might bleed, they might do this, or even you'll be surprised, someone say, if the anesthetist is the one that puts you to sleep during surgery, yes. Anesthesia, that they might put them to sleep and they won't wake up. Presently for anesthesia, you have what we call regional anesthesia. You'll be awake and be discussing, chatting with your doctors.
Is it trauma though, knowing that you are being operated?
Yes, but you won't feel any pain. You won't feel any discomfort, but you'll be discussing for those that are afraid that they might sleep and go to the other realm. Do you understand? Now, for surgeries, both for benign and cancer, you don't need to go under the knife anymore. You have endoscopic surgeries, you have laser surgeries, you have laparoscopic, where you're not opened up. Just through the urethra, the prostate can be blasted depending on the kind of condition you have. So we are doing advocacy to let people know that there are improved ways of adequately tackling your prostate problems. Do you understand? Absolutely. So that advocacy, and still the basic one about screening, we are still going about it, because when we get them, when we catch them, will I say young or early, the outcome, the prognosis is much, much better.
Absolutely.
Yeah.
Wow, thank you so much. It's been an interesting time with you, Dr. Anikwe.
Really
thank you so much for coming in today.
Thank you, Chigi. Thank you, Joshua.
Really.
And I really encourage you people, Signature TV. I didn't know about it before, but I'm really impressed, and Hope you guys,
Wow.
the sky or even beyond the sky
We
is the
appreciate
limit.
that.
Thank you.
Thank you so much.
You're
Thank
welcome.
you so much.
You're welcome.
There you have it, viewers. Advocacy, advocacy, advocacy. If you feel something, say something. Go to the hospital. Have yourself checked. Still on Signature New Day. And when we get back, our discussion continues. Do stay with us.